Afternoon, everyone, and welcome to the fifth in a session of our Imagining Innovations webinar. Please let me know if you hear me nicely.
Perfectly.
Thank you. I note that we have about 45 participants, and we are excited to have you here this afternoon. The Department of Family Medicine and Primary Care has been very innovative in bringing up launch hour conversations around emerging themes related to our experience of COVID-19, the pandemic. And we've had 4 to date, Wednesdays, and you can visit the website wits.wethu, W-E-T-H-U, to see the conversations that have happened in the past Wednesdays. Today, we're going to be looking at a very interesting theme. I am looking forward to a very authentic conversation and excited to have you all here from your busy lives, talking about something very relevant to us, which is mental health and fragility, lessons we've learned during HIV and COVID-19. So one thing we're going to be interestingly doing through our very mature panelists is trying to compare these two pandemics and look at what we've learned from both of them and how it's affected our mental health as a community, as students, as individuals, and as members of families. And to introduce our panelists, it's my pleasure to note that we have Pierre Brouard, who is the Deputy Director of the Center for Sexuality, AIDS and Gender. He's a registered clinical psychologist, and he's been working in the field of HIV since the mid-1980s. So that's a lot of experience, and working with the CSA and G since 2001. He's a manager, a researcher, a writer, a facilitator, a teacher, and the times that I've spent with him pre this meeting, I've enjoyed listening to him. And his interests include sexualities, gender, diversity, transformation, human rights, all within the context of discrimination, working against shame, depression, and stigmatization. His work extends to attention to mental health challenges, and he's been drawn into advisory boards for schools and higher education institutions, looking for ways to promote a mutually respectful learning community while addressing themes of diversity. Within the current pandemic, he's also focused on mental health challenges around young people, and this has been a special concern to him. He's an external examiner for MA thesis. He's a peer reviewer for a number of journals. He sits on the board for the Human Rights Development Initiative. He's a member of the executive of the Sexuality and Gender Division of the Psychological Society of South Africa. He's a member of ToxAIDS Reference Group, and he has served on the Transformation Committee of the Faculty of Humanities. I'm looking forward to having a conversation from Pierre. And our other panelist is someone I respect a lot within the WITS Faculty of Health Sciences Education environment. Nabeelah Bemath is also a registered research psychologist. It's going to be so interesting this afternoon. I literally feel like this is a therapy session for me. And she works as an academic coordinator with the Bachelor of Health Science degree at the University of Wits. She's a sessional lecturer as well with the university's Department of Psychology. And she's been involved with a lot of research supervision, teaching of research design and methodology, and student mentoring and support. Her work in the faculty has also involved curriculum oversight and development, and her research interests are focused primarily on public mental health, cognitive neuropsychology, cognitive neuropsychological assessment within the South African context. Nabeelah is also going to be speaking around her interests, which include research related to teaching and learning of health sciences students. So we have a very interesting panel. And because we're going to be speaking mental health and fragility, we're very mindful that certain comments, certain ideas, certain points of discussion may be triggering. And at the end of this discussion, there will be helplines displayed by our back-end crew that you can reach out to if you need support, and if you need to have counseling, if you need to speak to someone who is a professional around the challenges that you may have experienced with the pandemic. That being said, I also want to again appreciate the Department of Family Medicine for giving this space and for giving us this room as a community, both within WITS, outside of WITS, and to the international community as well, to have these discussions. I will now hand over the discussion straight to our panelists, and we'll be starting with Ms. Nabeelah Bemath. Nabeelah, thank you.
Thank you so much, Anastasia. So I just want to share my screen. Great, thank you again, Anastasia, as well as to the department for the opportunity to share some of my reflections on students coping and mental health during COVID-19. So when we talk about student coping and mental health within the context of COVID-19, I think it's important that we acknowledge the conversation regarding mental health amongst university students that has been taking place pre-pandemic. Generally, when we consider students within the university setting, these are students who would be classified as emerging adults. So these are students then within the ages of 18 to 30 years old approximately, and it's a period really characterized by various developmental shifts, which may occur. Things like living away from the family, forming new relationships, and these may expose them to factors that affect their mental health. And there's various literature conducted both internationally and locally that have documented the increasing rise in prevalence of mental health challenges that have been faced by university students, the concerns regarding this and the needs to address this. What COVID-19 seems to have done is it seems to have exacerbated the challenges that young people face, and consequently their mental health. So in my experiences in interacting with students in the different spaces that I have the opportunity to engage with them, one of the key things we've seen is the direct impact that COVID-19 has had on student mental health. So specifically things like anxiety around their own possible or confirmed infection, the infection of a loved one, issues related to death and dying, including bereavement due to loss. And in this context, students have also then had to adapt to the pressures, the demands, the newness of online learning as well, and the factors that come with that. So things like forming different kinds of peer relationships, the lack of face-to-face interaction with peers, the need to become self-directed learners, etc., which have created a sense of isolation among students and an added source of anxiety. And I use the term anxiety a bit loosely here. COVID-19, very much like HIV/AIDS, has also brought to the fore a lot of the socioeconomic inequalities that exist within our context. And we've definitely seen this within our students. And the impact that this has then on student mental health. So for example, in relation to online learning, we have seen some of these inequalities. Students who were unable to access residence or campus as they live far away, but at the same time don't have access to devices, who have to travel kilometers in order to reach a point where they can actually connect to data and access the data that we've provided to them, or to get electricity to charge their devices, who did not have devices to study and had to go through all the processes in order to request a device, etc. So these are some of the impacts we've seen in relation to that. We've also seen the more indirect impact in terms of socioeconomic inequality, such as the loss of a caregiver and consequently the loss of support from that caregiver, be it physical, economic, etc. Their loss of ability to travel, to access resources, and that sort of thing. So these experiences, coupled with the pressure that these students face in relation to the academic workload, And, family expectations with regards to academics, etc., seem to have negatively impacted students' mental health, consequently their academic engagement, which then seems to then exacerbate the mental health challenges they face and kind of forms a vicious circle. So we have had to be innovative in terms of how we've tried to support students throughout this process. And I really do emphasize the word tried, because it really is a learning curve for all of us. So as with other forms of learning and support provided through the university, we've had to move online, and this has meant using platforms like MS Teams, hosting individual support sessions or large group consultation sessions, telephonic consultations with students to support them. But we've also tried to innovate in different ways. We've formed a we've formed a site on our learning management system specifically geared for our students. And while we've had this pre-pandemic, in the context of COVID-19, we've really tried to change the kind of information we present, how we present the information in order to make it more effective, etc. We've also had to be flexible in terms of where and how we communicate with students, using platforms like WhatsApp, for example, communicating over email what we would have done face-to-face, finding different ways to do this, sending students voice notes over email and that sort of thing. We've also had to definitely increase the frequency of our communication with our students in these different platforms as well. And in this process, really reflecting on our ethic of care as university staff, and then how do we then implement this within our work? So through this, or related to this, is also then how do we facilitate peer interaction and skills-based learning? Because these students don't have the opportunity to engage with their peers face-to-face, and that sense of isolation that creates, we've attempted to create forums for students in which they can interact with their peers, trying to keep it informal, to give them a space to interact with and just form a connection that they would have perhaps had the opportunity to do face-to-face. And then with regards to skills-based learning, really providing students with sessions, guiding them around navigating the challenges of online learning, for example, how to become self-directed learners, how to manage time in the context of online learning, and that sort of thing. We've also really increased our collaboration with other support programs and structures within the faculty and university to address resource-related challenges that have been experienced by students that have been impacting their mental health, or issues related to mental health challenges directly. For example, liaising with our faculty's Office of Student Success and the support programs they have on offer, reaching out to them to deliver additional support programs to our students, which we are very grateful for. So this is quite anecdotal, but interesting findings have also been obtained within research conducted on student mental health during COVID-19. So a study that I was privileged to conduct with colleagues of mine from the School of Human and Community Development with regards to undergraduate psychology student experiences during COVID-19, we found some interesting findings. We found that while students had their scores on the mental health scales were not necessarily raised, and they did display adequate coping and resilience skills, when we looked at the responses to open-ended questions that we had asked in this research, we found that students reported symptoms indicative of possibly appropriate, given the circumstances, subclinical levels of depression, anxiety, burnout. So the reported feelings of fear, helplessness, anxiety, loneliness, etc. It is also possible that the scales that we used didn't pick up these levels of depression, anxiety, and burnout. But as I said, we also need to consider it might have been an appropriate response given the circumstances. We also found students highlighting challenges that they face with regards to online learning. And this was both challenges in terms of practical learning related challenges, but also emotional difficulties that came with online learning. Students also frequently mentioned the home environment, where increased responsibilities affected their well-being, but also the impact that support from others within their home environment had, and finding value within the support, and students who were not receiving support in the home environment flagging that as being an issue for them. So a similar study conducted by Visser and Law van Wyk, also with regards to university students' mental health and emotional well-being during the pandemic, and this was conducted 3 months into the pandemic, also found similar findings. They found that students subjectively reported coping difficulties as well as poor psychological well-being. And really what they found was that students' sense of hopefulness most predicted students' mental health. In having shared the above reflections and research, I think what's important to also note, and based also on my interactions with students, is that it's important that we don't view students from a deficit approach. We have seen students show resilience in extremely difficult circumstances in terms of overcoming these difficult circumstances, and really through, and this is through their what we would call, if we're looking at the resilience literature, really accessing resources through reciprocal interactions with close others, with the university and with other resources within their socio-ecological context. So having said this, and reflecting on these experiences, I think the next question that we ask ourselves is, well, where do we go to from here and what is the way forward? How do we innovate going forward from this in terms of how we support students and how we address these issues related to mental health? So I think one of the key things is that while we anecdotally have knowledge of what these challenges these students face, it's important that we do further research around the factors that impact student mental health so that we can identify what these factors are and how do we then go about addressing this. Related to this is then identifying what factors actually promote resilience of the students and how do we as staff within the university context, how do we go about facilitating students' resilience within the capacity that we have? Another thing that I've gained from my experience with students and the kind of interventions we have adopted is to gain student input on the interventions that are being implemented or can be implemented. Students need to be active participants in their mental health, and also what interventions we think might not be working might actually work, or the opposite. In some of our communications we've been sending to students, we might not necessarily get interaction from students in terms of their responses to those sorts of communications and interventions that we have. But in informal communication with students or in an interaction you have at a later point, you can then identify how those interventions actually assisted. So it's important to get the input on this. And then also considering how do we address student challenges in relation to our curricula. So when we're looking at redesigning or developing curricula, how do we develop our curricula to be inclusive and grounded within an ethics of care in order to address these kinds of challenges? I think another thing the pandemic has done is really made evident the need for mental health services and support for students. And so we really need to continue raising awareness around issues of mental health, as well as reducing the stigma that comes with mental health and seeking help for mental health. And then related to this is really opening up broader conversations within exosystemic and macrosystemic structures in order to impact on policy and resources that really impact on student well-being as well. So I look forward to engaging with you all within the question and answer session. And thank you very much again for the opportunity to present. Thank you, Anastasia.
Thank you so much, Nabeelah. I've copiously making notes here for myself. I have a few questions to ask, but very interestingly is what you spoke about. You know, the stigma around seeking help, even for students, and I'll just want to get that. You know, you've reflected from a student's perspective. I just want to call in Pierre to relate his experiences with the HIV pandemic as it were, and relate that to what we're currently going through, and let's just see how there is an intersection or a relationship between both. Pierre, thank you.
Thank you, Anastasia, and I appreciate the invitation to be here today. I very value this opportunity. So I've titled my remarks, "The Lies That Bind, the Strength and Fragility of Bonds of Belonging." And I based that title on a book by Kwame Anthony Appiah called "The Lies That Bind." And in this book, he argues that the bonds of belonging through, for example, race, ethnicity, gender, sexuality, and religion are sometimes based on fantasies of a shared identity, and that these bonds may be more fragile than we think, although I suppose we could also say at other times they may bring forms of support and community to us. And so a lot of what we think about of as identity is based on the stories we tell ourselves about our group. Who is the we that we get to draw on in times of need? And all of our stories that we tell about ourselves are subject to fabrication and embellishment. And I suppose I wonder, in thinking about COVID and in relation to HIV, what stories will we tell about COVID when we look back on it? So in these brief remarks, what I want to do is to think about the two epidemics together and where possible link it to our university context, which I think is grappling with two key questions. Firstly, how do we make our universities safer in relation to this new pandemic? And I think it's important there to bracket the idea that we need to think about safety beyond the individual capacities of our students and staff, but also to think about systems and structures that make safety more possible. And my second question in relation to universities is, what is a university if we no longer meet in person? What kind of community is it that we want to create or that we feel that we belong to? I position myself in this discussion today as an older white gay man who's now educated and middle class. And in those identifiers, I've experienced both vilification and privilege. And this keeps me alive to the ideas of contradictions, which I think are surfaced by both the epidemics that we're reflecting on today. When I encountered HIV as a white gay man in the early 1980s, South Africa was in the last throes of apartheid, and I was a partial citizen, as I like to think of it, because of my sexual orientation. But most Black South Africans were denied full citizenship. So there was a way in which we were both joined in the Immorality Act as being seen as less than in some way. And when I qualified as a psychologist, I moved into the realm of being a professional citizen, and that accorded me some status. As an aside, I think it's interesting to think about Susan Sontag's ideas, which she formulated in relation to sickness and then and HIV, when she said we are all born into the kingdom of the well and the kingdom of the sick. And depending on the illness we have, we can move quite seamlessly from one to the other. To put bluntly, I would say that HIV cut a swathe through the white gay male community in the 1980s and into the early 90s when ART arrived by 1997. One of my earliest memories was of seeing an old school friend of my then partner who came back to South Africa, in a sense, to say goodbye before he died. He was diagnosed with HIV, but his key response to it was silence. And I would argue that silence was the key defense mechanism of that time. It was a shield against the horrific stigma and blame and shame that came with the diagnosis. But the problem for HIV of those times is that your body betrayed that silence. So weight loss, the lesions of Kaposi's sarcoma, CMV retinitis leading to blindness, swollen lymph nodes, and even dementia were in effect spoke volumes against the silence that you were attempting to retreat to. And even some of the early ARVs produced marked body changes. So many gay people retreated. They retreated from HIV, they retreated from the stigma and the shame, but they also retreated from their community, denying them the important resources that they need. And of course, we know that the stigma and shaming around it was not only because HIV was a dread disease, if you like, but because it was also associated in its early years with sex work, with drug use, and of course with being gay. So the stigma in effect serves the purpose of shaming and splitting and dividing the world and the community into us and them. We are morally superior, therefore we are not likely to contract HIV. In the persons doing the shame, from a psychological point of view, we are also seeing the phenomenon of splitting and projection, because in effect, what we are taking is the darker impulses in ourselves and projecting them onto the other. So not surprisingly, this shame becomes internalized, and it colludes with internalized homophobia. And this had devastating mental health consequences. And all of us who lived through that time could tell about some terrible things that happened to people living with HIV in the way that they were treated. Let me be clear, there were many stories of heroism, collegiality, and comfort, and many activists and in the NGO and queer space pushed back against the stigma. I recall how two doctors at the then Johannesburg General Hospital, Steve Miller and Dennis Sifris, had to fight tooth and nail to win the right to run a weekly HIV clinic, where I spent some of my internship year as an intern psychologist. And I think because they were both gay men who saw how devastating this epidemic was, that they needed to provide support and treatment and help to the gay community. For me, what has been fascinating with the rise of COVID has been the depressing familiarity in some ways of shame and blame. I think this is beginning to shift a little, and I think the similarity with HIV is that as the phenomenon became less deadly, stigma did lift to a large extent. So in the case of HIV, antiretroviral therapy, I think has been a game changer. And I would argue that in relation to COVID, the rise of vaccines has seen a diminishing of some of the early forms of shaming and stigma. But I remember last year in writing an online piece for my center about COVID and shame, a story of a Polish professor who was driven to commit suicide because rumors had spread that he had not complied with his quarantine. But in fact he had, and his lawyer said he'd taken his life as a result of a wave of hate that he faced online. There was reports of increased suicides in France, people not only scared of COVID, but they were also scared that they had infected other people. And here in South Africa, I recall a story of an Eastern Cape woman who arrived at her homestead after a COVID diagnosis, finding her belongings left on the gate. Essentially, she was told she was not welcome. I think we've done a lot of shaming in the early years of the COVID. We shamed lockdown transgressors. We shamed smokers and drinkers. People who wanted cooked food were called spreaders, a work, in my view, that is naked in its blaming and othering. And there were also questions around people's loyalty to the state, to the country. If you were a spreader, in effect, you were not a good citizen. Never mind, I think that the real betrayal was the state's inability to shield the poor from the effects of COVID and some of the strict lockdowns that we had. I had COVID in December last year, and I can safely report that I did feel guilt and some shame, even though I'd done my best to avoid it. When you reveal a COVID diagnosis, even today, I think the first question people ask is, where do you think you got it? There's an implicit judgment in some of those questions. And I felt guilt about passing it on to my family. And I had to deal with that largely on my own. So of course, I survived just fine. But I wonder, as I think Nabeelah has suggested in her presentation, whether we've had a proper reckoning with COVID from a psychological point of view. Not only the unexpected losses of loved ones dying suddenly and alone, but the isolation in general and the disintegration of life and community as we knew it. I think a number of those things have had an effect on our senses, our ties of belonging and what we think of as our community. Those of us who lived through HIV have some thoughts about that. I think one of the responses of the gay community was, in a sense, to reinforce the notion of community. And in the face of state inertia, often that was the one thing that was the buffer between the gay community and extreme forms of isolation. Not unlike Nabeelah, I'm drawing to a close now, Anastasia, in case you're watching the clock. In my center's interaction with students in our volunteer program, we've heard about students not being able to communicate well with their lecturers, being overwhelmed by online platforms, grappling with monitoring software during exams, feeling isolated, struggling with making friends and getting to know their fellow students. There are students who've never attended a class with other people in the same space. And this was especially true for some queer people who may have come to university to find some of their early bonds of support. Students battled curfews, accommodation, and part-time work, and of course they had to deal with misinformation around COVID. So apart from the personal and intrapsychic burdens and university-based burdens that I think some students, perhaps many students, have experienced, I believe we are also being asked to think about mental health through the lens of the social. What are the communities we can draw on? Who are my people? Are they up to the challenge of supporting me through this epidemic? And also, what is a university? What is a university if not a community of critical thinkers? As we grapple with vaccine mandates, do we need to think about how we bring people along the vaccine story, or do we run the risk of shaming people who are anti-vax? And I think I probably have been not very good at that myself, and wondering, you know, how people could be anti-vax, and that I've probably flirted with shaming them myself. And I think we can do better. I think we need to ask, what are we prepared to sacrifice to rebuild our university communities, even if they sometimes feel like an imagined community, or even a transient community, or a set of communities. Thank you very much.
Thank you so much, Pierre. Very, very reflective conversation, lots of thoughts to think through. And we have the questions and comments already coming through. But as you made your comments, it led me to think about personal experiences, you know, with students, and the whole idea that community can be a support, and community can also be anti-support in terms of stigma experiences, I think is something we need to pull out and flesh out more. I remember the odd students who, knowing that going through the screening questionnaire very honestly may exclude them from being in the class setting. And so you had students who would prioritize their personal being in the space for exams over and above the health of others, because they felt they were going to be excluded if they said, I've been in contact with someone in the past 14 days with this. Just thoughts. And while you mentioned the we, and reflected on the HIV and the COVID challenges around stigma, shame, and a sense of community, the theme that came to my mind was social fault lines. Nabeelah has talked about student communities. You've spoken about reflecting on both pandemics. We have a question that has come through from a few participants, and I'll just read out one. So Terry wants to know if the infection from COVID-19 very clearly has an us and them happening the way it happened with HIV, and I think you've spoken to that, but you can expand. He also wants to know around mental health related to the pandemic, especially as there is research coming out to say that the next big pandemic is the mental health effects of COVID. So he wants to know, is it possible, and is it the same, that we have a we and us, or an us and a them happening with the mental health related to pandemics in general? Pierre?
Thanks, Anastasia. Maybe Nabeelah, you could take the mental health question. I'm thinking about the us and them question, and I, in all the years of working in HIV and HIV stigma and anti-stigma work, I kind of came to the conclusion, which is a little bit depressing, that the tendency to form in-groups and out-groups, the tendency for societies to other, to exclude, is somewhat wired into the social condition, and that in some ways there is a very instrumental basis to stigma, which is it's the original social distancing mechanism, that if we keep people who we perceive as dangerous away from us, then we create the illusion of safety. I think that it's important for me to think about stigma not just through the lens of the interpersonal, but also through the lens of its social function. And I think that the work that we need to do is to break down some of the, first of all, the misinformation. We need for our information to be really succinct and clear and well thought out. And I know the challenge around COVID was that this was a moving target. We were learning about information all along. So it was quite difficult to give a consistent and coherent message from the very beginning. So I think the messaging consistency and the factual basis is important, but we also have to acknowledge that stigma is also rooted in social processes, ways in which, what are the vectors of influence in our society, whether it be media, social influences, people who hold positions of power have the ability to change the narrative around people are living with COVID or people who are living with HIV, and also for people who survived to tell their stories. I think the early HIV work really rested on the activism of people who were living with HIV. And I've seen some of that very successfully done in our media. When stories of COVID survivors have come through, it restores their humanity and rebuilds our sense of community with them.
Thanks so much, Pierre. So maybe to add on that, in order to answer the question whether that's the same for mental health, I think very much so. It comes down to that in-group, out-group aspect where we fear what we don't know, and so we kind of divide people into us and them, and that's part of the reason of why there is the stigma. One of the things I think COVID-19 has done is it has increased the conversation around mental health, but I think we really need to go a lot more further around reducing that stigma, breaking down the kind of language and discourse that we use around mental health to reduce the stigma and to reduce that us and them approach to mental health.
Thanks so much. So I'm just going to put together a few questions that are, thematic. Some of the students, some of the participants, it's the teacher in me that keeps referring to students. So want to know, and so I'm going to lump this together. How do we help reduce the stigma of seeking help in schools and universities? And as you reflect on that with your inputs, can you just also link into the question that says there seems to be a loss of intimacy, a loss of friendship with people outside our direct households, with hard lockdowns and the levels. I know that now in varsities, most reses won't allow people to come visit. Personal experience, people wanting to see family members, things like that, no longer acceptable. So how do we get people to feel trust? Glenn wants to know, in being together in universities or colleges or schools again, even in the work spaces, how do we develop this sense of community? And then those who really want to seek help within the school setting, how do we encourage breaking down any walls around stigma that has been built up with COVID? Nabeelah, do you want to start with this, or Pierre? Nabeelah, thank you.
Sure, I'm happy to start. Thanks, Anastasia. So I think let's take it systematically. I think one of the first things you mentioned was, how do we go about encouraging, seeking help and reducing stigma within schools and universities? That's quite a difficult question, because stigma is such a broad term and there's so many different types of stigma. So perhaps that's one of the things, identifying what kind of stigma exists, and then using different strategies to address it. One of the things would be knowledge dissemination, increasing awareness around mental health challenges, using discourse that normalizes mental health difficulties, and then seeking help, making resources available for mental health, whether it be through the provision of a school psychologist, or opening up conversations also around mental health in the different spaces, incorporating those kinds of discussions within the curricula. So those are just some of my thoughts around that. But it is, as I said, it is quite complex, and it's not a single answer to address it. But I hope that gives some direction going forward. And then just in terms of building trust as well, and I mean, that's also quite a difficult question. I think it's going to require a period of adjustment in the same way we had to adjust moving from pre-pandemic into a pandemic and lockdown, etc. I think it's going to start with smaller group learning, tutorial-based learning, and that sort of thing. I think it's also important to keep in mind that, yes, it has been that sense of isolation and that sort of thing, but also we have still been engaging socially to a degree online. And I think building on those relationships that have been built online, to whatever degree that may have been, and whether they have been successful or not, that's perhaps another matter that can be debated. But I think capitalizing on what has been done, the relationships that have been formed in those spaces, and using that to kind of build the trust going forward.
Thanks, Nabeelah. Building on that, my thinking about those themes that you brought together, Anastasia, is the idea that there cannot be a life without risk. And I often said to people when I've reflected on how I feel about navigating life through COVID, having lived through HIV, is that at that time, certainly as a member of the gay community, we reached a point where we realized life had to go on. And that we found a way to make a kind of peace, maybe a truce, if you like, with risk. And to acknowledge that to be human and to be social, we had to continue to engage with life and with the world and with relationships and do our best to be safe in that. And I think and what is interesting about COVID versus HIV is that in some ways, COVID is much more infectious and more contagious, if you like, through just merely being in the same space as someone. But where HIV wasn't, but it was transmitted mostly through acts of extreme intimacy. So that also had questions of trust sort of woven into it. And I think what universities could do is to acknowledge that they have to make some tough decisions about vaccine mandates and to play open cards with our community or communities and say, come back, let's work within the parameters of risk and have these conversations and rebuild what we had before. It may not ever be the same, but ultimately, I think we are moving to a world where regular vaccines will mean it's more possible for us to spend time in the same space as each other. But these are complicated questions, as Nabeelah is saying. Rebuilding trust is a difficult task.
Thanks, Pierre and Nabeelah, for your insightful comments. Very interesting comments coming in the chat function, because this is a very reflective topic. Something Victor wants to know, he says, is it possible to imagine that the aspects of intimacy and body proximity are included in the stigma around HIV and COVID being transferred through close contact? Yeah, just think about that. I'll just read out the comments from Dr. Makunga. She said, the sad thing is how we, especially within the health and wellness industry, see or perceive ourselves. We are a very busy crew traditionally, and we forget to support one another. When there's an acute lockdown, and even later, many of us are still suffering complications and outcomes. People are feeling isolated in their suffering. Some people are still suffering long COVID, but because they have noticed that life is going on as normal, they have learned to hide their suffering. And I think that, Pierre, you had mentioned that somehow when you spoke about the fantasy of a shared identity, how can we as community, so it's a lot of things, I'm throwing out everything, mindful of time. So first off to you, Pierre, how can we, reflecting on that concept of the fantasy of a shared identity, we all are together in the same workspace, and someone has had to go through COVID, go through the physical isolation, and is now going through an emotional isolation and is suffering. And this is coming out in ways in which there's a delay in the pace of the teamwork that they are part of, or they're manifesting with anger and a lack of cooperation and kindness. Then Nabeelah, okay, let's start. Let me not throw out too many things. I think I'm getting too excited now.
I can throw out some ideas, Anastasia. Thanks. You know, it's not surprising that that ACT UP in the early years of the HIV epidemic, particularly in North America, used the slogan "Silence equals death," and I think what COVID has done is that it has forced a lot of people into silence, partly because of shame, but also partly because the fear of passing the virus on to other people. And I think as vaccines allow us to shift some of that isolation, we need to normalize the sharing of our stories and our journeys. Because I think that humanizes us, and it allows us to build empathy and to form the kind of bonds that I think keep communities alive. But I also think we need to recognize that bonds of belonging can be fragile and can be tested. You know, HIV, not unlike COVID to some extent, HIV was able to shatter even, for example, family bonds. And you hear stories in South Africa, but in other countries, I've read stories about family members no longer speaking to each other because half the family were anti-vaccine and the other half were pro. So that says something a little bit depressing about the power of the fear or I guess anxiety is about the ability of the state to impose its will on the individual. It says something about the power of those phenomena to split what even appeared to be before quite strong bonds. So I think we need to be mindful that there isn't a panacea. But I do think ultimately, I mean, Nabeelah, you and I as psychologists would argue that it's human connection that is the most healing. We are designed as a species to touch. And I think that's been a very damaging part of COVID, is that we've stopped hugging and touching each other and being intimate in that way.
Thank you very much, Pierre. Nabeelah, do you want to add anything to this? Have you, with your research, and you mentioned a lot about resilience, and you did give very helpful input around the ways forward. You also spoke about the ethics of care. Do you want to expand on that a bit as we look at, how do we go forward from at this point? We're talking about community. We're talking about the fact that we have to build on the sense of sharing our stories, like Pierre has mentioned. Can you speak to us from a student's perspective? What does ethics of care mean to us as healthcare workers, as people in community, as a medical fraternity, or as an educational fraternity, or as people in whatever is our identification of our we? And while you're speaking to that, someone had asked us the question, how will VITS look out for blind spots in a way that would avoid early mistakes with the HIV pandemic? What blind spots do we potentially have that we need to make adjustments for as we contemplate healing our mental space? Thanks, Nabeelah.
Thanks so much, Anastasia. So I think when it comes to ethics of care, it depends on who you're looking at when they're defining ethics of care. But essentially, how do we interact with our students, both in terms of the kind of direct interactions we have with them, as well as through the kind of teaching and learning that happens within those spaces in a way that respects the student beyond just a number in the university system. How do we incorporate that? How do we consider the factors that are impacting the students beyond just within the university setting, that definitely impact them in terms of how they engage within the university setting, within their academics, but acknowledging that and playing a role in terms of as I said, facilitating their resilience or identifying factors and supporting them within, we are constrained within the limits that we have, of course, but also then opening up spaces to increase the kind of support that we can afford to give to the students as well. So in that respect, that's what I mean when I say adopting an ethic of care, coming from that space, acknowledging the student within their whole as a person, rather than just the student who comes into your classroom, learns whatever you teach and then leaves, because it does go beyond that. So I hope that answers that question. Do you mind just repeating the second question again, please?
Yeah, so someone wanted to know, with the HIV pandemic, Pierre, some of the things you spoke to, that led to silence, and I think that's where the differences within the pandemics lie. With COVID, we've had a very rapid response. The vaccines are out, the public health messaging is out, we have lots of things happening, but there may be blind spots that as a university or as, different workplace communities, we're not focusing on. We are so, we have so much of the statistics in our face. We have so much of the things happening. Are there blind spots that we could potentially miss within our communities, especially as universities or as a medical, or as VITs?
Yeah. Nabeelah, are you going to speak to that, or should I kick off something?
I'm happy for you to kick off, Pierre.
Thanks. I don't know if this is answering the question entirely, Anastasia, but one of the things that my center did when it started in 2000 here at UP was to think about how we work with students, not only through the medium of engaging them around sex and sexuality and HIV messaging and how to be safe and providing really good sexual and reproductive health services. I mean, those were all very important. But I think one of the other things that we did quite successfully was to get them to think critically about what this epidemic means and what it says about their role as young people in creating a future society. So I think that angle of a kind of critical consciousness coupled with intellectual inquiry, I think also when it was added onto some of that other kind of quite standard HIV prevention stuff, was exciting and invigorating. And it got, because this is a place ultimately of critical inquiry, it got young people thinking about what it means to be a citizen, an active citizen, or an active citizen for social justice. And I think that kind of thinking could be one way to step back and interrogate, have we actually responded appropriately to COVID? And I think it could be useful to bring in people who did work through the early years of the HIV epidemic and to say, what were the lessons that you learned there that we could bring into our current understanding of this new phenomenon?
Thanks, Pierre. So I think we really need to do more, particularly within the context of mandatory vaccinations and that sort of thing, and the ethics around that, and kind of what we inform students, what their roles are, and particularly if we're looking at students within the health sciences, what are their roles in terms of their role as health scientists in the future going forward. So reflecting on that and how we kind of incorporate that within how we interact with students and that sort of thing, I think that's something we really need to think about and build on.
Yes, Pierre.
Thanks, Anastasia. I just wanted to comment. There was a comment / question from Elisma in the chat, which I thought was interesting to reflect on. I know we're coming to the end, is around monitoring software in relation to students and exam writing. And I think that's an interesting question because it speaks to the idea of a trust deficit or a potential trust deficit. I know that obviously the university has a duty to ensure that the student is sitting the exam in an honorable fashion. But I think, something that has crept into all of our universities a little bit over the last decade is a kind of viewing of the student as a commodity or as a product. It's a kind of the business models dominate, and are we seeing them as people who must meet throughput requirements, or actually actors whose lives and feelings and experiences matter to us? And are we really building the notion of community, or rather than seeing them as objects, as instruments for a goal of becoming the best university in Africa, for example?
No, it's 1 hour has been like 10 minutes. There's so many things that I would really love that we would have extra time to, continue this conversation. But hopefully, one of the objectives of having this Imagining Innovation session is that people start reflecting and start thinking through, students, how do students identify themselves? Do they look at themselves just as a product, like you've mentioned here? Or are they seeing themselves as a solution, like Nabeelah mentioned, students becoming involved in research, becoming involved, seeing themselves, their future selves as health scientists? One of the students that I know, mentioned, sorry for that glitch. One of the students I know mentioned the fact we need to start educating communities. And I think going away from here, as we imagine innovations, let's see how we become very participatory and active in our involvement in communicating, and in fostering community, and in fostering resilience, and in speaking about mental health around things that are real, with the masks, with the physical distancing, with the isolation, the quarantine. One of the chats mentioned the messaging or the words or the vocabulary that has come out of this pandemic in itself is almost like a trigger for mental health issues. It's quarantine, it's isolation, it's mask, it's physical distancing, it's, so all that. So we're looking forward to continuing this conversation in another space. I would like to just mention again that if there's anyone as a participant who identifies as a struggling student or a struggling workplace colleague, there are helplines. There are psychologists who are available to speak with, their counselors. There is a whole resource for VIT students and staff, Office of Student Success and CCDU. And for those who are without the VITs or university environment, these helplines are available on the website, the vits.wetu website. You will see these resources. Please speak to someone. Please have a conversation. Nothing is irrelevant. And on this note, I would really love to say thank you so much to Pierre and Nabeelah. I've enjoyed chatting with you, and I could go on listening and listening for hours on end. But we, as all good things have to come to a close, it's 1400 on the dot, and we don't want to also become part of someone else's mental health issues today, as they with crowded timelines and online. So next week, can I just say to our participants, thank you for being here. Thank you for your helpful comments. Thank you for those who have followed the series from 5 Wednesdays ago. Next week, we're going to have the essentials, the arts, music, and the food of life. We have Gavin Craston, Kutwano Masote. I've heard him on Classic FM. I'm looking forward to that conversation. Sarah Hallat, and our host is going to be Stephen Pence. I also want to use this opportunity to just say thank you, a big thank you to the back end. Our participants, we have people in the back end who make this worth your time. Thanks, Mangaliso Kelobohile, Catherine, and Stephen. I've enjoyed this conversation, and I'm looking forward to other opportunities. Final words, Nabeelah, Pierre?
Thank you very much for the opportunity to share my thoughts, and for the very thoughtful reflections, and for Pierre for sharing the space with you, and Anastasia, the back-end team, and the department for the opportunity and for all of the assistance throughout the process. And to all the participants, of course, for their thoughtful comments and questions. Thank you.
Thank you, Nabeelah. Thank you, Anastasia and the team. I really enjoyed being here, and I hope the conversation carries on. So thank you so much.
And on that note, thank you everyone for giving us an hour of your day. Bye from me. Thank you.